And the satisfaction rates, I know it's been frustrating for many people, but the satisfaction rates with the coverage have been quite high. They're up close to 90% of people who are fully or partly satisfied with the coverage. And we also wanted to bring it in at lower than expected costs. And the costs right now in the program are running about 40% below the initial budget projections for what this program was going to cost before it was implemented in 2006. A very important reason for that is that almost no one is in the standard drug benefit that was in that law that was designed by Congress. The standard drug benefit was, had a deductible, then 25% coinsurance, then catastrophic coverage on the back end. And between that, there was the famous donut hole. You guys remember that, if familiar with the program? By the way, if the people had now the budget estimates, the cost estimates, had then the cost estimates that we have now, there wouldn't be much, if any, of a donut hole because the costs have turned out to be so much lower than expected. But the Congressional Budget Office doesn't let you go back and adjust like that. Usually the health care cost estimates go in the other direction. They turn out to be a lot higher than what had been projected. There are a number of reasons why costs have turned out to be much lower than expected, but one very important reason was that people chose a different benefit design than what Congress had envisioned. Almost no one is in that standard benefit that I just described. What people have overwhelmingly chosen is what's called a tiered benefit, where if you use a generic drug for treating your health problem, it may cost you $1 or $2. Some plans have them available for free. You pay almost nothing. If you use one of the so-called preferred brand name drugs, where the plan has negotiated a lower price on the medication in the class, and there are about 11 classes of medicines that account for most prescription drug spending among seniors, most outpatient prescription drug spending among seniors. Well, that preferred brand name drug will cost you a flat $20 or $25 a month, and most other drugs are covered, but people pay a significantly larger part of the cost for them. They're on a higher tier in the plan. And what happened in the implementation of the benefit was two things. One is that people overwhelmingly chose this benefit design that had lower premiums and lower cost per person. And then two, people switched drugs. The use rate of generic drugs among seniors in this country is now, in Part D, is up to about 65%, almost 2 out of 3 of all prescriptions. That's much higher than it was in 2005. Then, and in Medicaid today, generic drug use rates are only running about 50–55%. Now, there's been a lot of discussion about getting the prices down for Medicare Part D drugs, and there probably is, there may be some more steps that we can take, and we should keep looking closely about whether there are good ways to do that further. But when you switch from a brand name to a generic drug, you don't save 5 or 10% more in additional discount. You save 70 to 80% off the cost of the medicines. When you switch from a non-preferred to a preferred brand name drug, savings are typically 20 or 30% or more. So by switching the drugs, the cost of the program turned out to be much lower than expected, and this was driven by patients. This was driven by patients getting